This research is on a pilot characterization study assessing health equity and mental health care delivery within the state of Georgia. My name is Jacob Zelko, and I'm the coordinator as well as the principal investigator for this work. And here is a list of also my wonderful and amazing student assistants who've worked on this project so far. So to give some background, established background on this endeavor, is that mental health care, as most of us, or maybe many of us will know, varies across various populations. This can be due to reasons such as internal reasons, like one's own beliefs and attitudes around mental health and mental health care, and external reasons such as socioeconomic factors, insurance status, or experiences in the past with different sorts of care providers. So the goal of this project is to, well, the goal for this initial pilot characterization study was to characterize populations with mental health conditions, investigate prevalence of mental health care, and utilization of mental health resources in rural and urban US communities. So there were two broad targets, and I'll unpack that a little bit more in further slides. But the first target was to identify vulnerable populations and their characteristics. This looked at leveraging claims data, electronic health records, et cetera, to develop clinical phenotypes around mental health conditions. Furthermore, our focus, particularly for this pilot characterization, was around the chronic mental illnesses of depression, bipolar disorder, and suicidality. Furthermore, for this pilot characterization, as this is the first network study being conducted at Georgia Tech Research Institute, my home institute, we were doing this to enable large-scale observational health research. So not only could we engage with the OHDSI network and community using a federated research model, but also build capacity and partnerships to be able to conduct either further network studies here at GTRI or partner with others at our location. More on that in a little bit. So to get into what I mean by characterization, as many within the OHDSI community might already know, when I say characterization, I mean thinking around characterizing individuals seen for mental health care at least once across various axes. These axes can include one's condition diagnosis specifically, their age group, their race, their gender, location, et cetera, and also asking the question of their intersections, as intersectionality theory in medical sociology talks a lot about how these intersections can compound or have non-additive effects of possible health inequities occurring within populations. And so for the initial characterization that we did for this pilot characterization, we did a baseline characterization, which looked at characterizing individuals being seen for mental health care services related to one of the disorders that I mentioned earlier, at least one time, and this includes hospitalization events. And although for this pilot characterization, we were able to pursue this question a little bit, we were not able to, or we're not at a stage yet to present results exclusively on this follow-up question yet, but a secondary characterization that we're doing is the follow-up characterization, loosely called follow-up characterization, which looks at characterizing patients who are seen only one time for mental health care services. And some areas of interest include, how do the characteristics of patients who are seen only one time for mental health conditions differ from those who continue to receive care? And as you can see, there are a couple other questions that we're examining too. For sake of time, I'm going to go ahead and get right to the main crux, or some of the early findings from this initial pilot characterization. So this was the poster I presented at the OHDSI Symposium. I know it's really small, so we won't spend too much time on it. But thank you all so much for your time at the OHDSI Symposium. It was wonderful presenting to you all there. But to recap on what that poster and what we did with this work, so the data that we used was approximately 2.2 million Medicaid patients from the state of Georgia, and this data ranged from patients from 1999 to upwards to 2014. As this data is a bit older, we did use ICD-9 diagnosis codes for our definitions, and also the coding that you'll see across race and various sort of groups follow the OMB categories, which also have recently come in under scrutiny. So I'll discuss more about that in a little bit. And then finally, with this Medicaid data, the files that were used were CMS Max files, and we used the personal summary, inpatient, other services, and prescription drug files to do our analysis. So just to do a quick breakdown of these 2.2 million patients, here is a quick breakdown by race, gender, age group across the state of Georgia, this data that we're using. As you can see in figure A and figure B, the whites and blacks or African American population comprised the largest portion of this patient population, where the other race category, which is a category that comes specifically from CMS and Asians, race-based categories also are accounted for less of the overall population. So the methods that we used to do this pilot characterization study, as it was a very simple proof of concept, we did basic stratification algorithms to build up intersections across race, gender, and age groups, looking at the conditions of interest being depression, suicidality, and bipolar disorder. And we did a crude prevalence calculation across these different subpopulations that arose from these intersectionalities. Seen here are two equations. Equation one is the standard equation for calculating period prevalence, where the C on the top are those persons matching to our phenotype definitions of those individuals who have the condition. The large N representing those patients who match to our entry criteria, but regardless of whether or not they have the condition, being depression or one of the other conditions. And the little p represents period. In figure 2, we actually simplified that equation significantly to just C over N, as we decided that the period we're going to look at was the entire period of the available database, which was from 1999 to 2014. So we had C over N for calculation of period prevalence. So moving forward, so the crude prevalence of depression in Georgia subpopulations are quickly shown and broken down across these various race groups: white, Black, or African American, other race, and Asian. For the visually minded, here is the plot showing how these prevalence rates broke down. But then for more the hard numbers, here is some of the interesting comparisons and find like actual metrics that we're able to calculate. In particular, I would want to highlight the ones that are highlighted red, which are shown in the other race and Black or African American categories. What this means, like what the red value means, is we compared the crude prevalence rates for each of the subpopulations within each various category to its analogous white subpopulation. So in this case, what we did was, for example, the other race category for male prevalence rate in the other race category for ages 40 to 49 who are male, we compared that to the analogous white subpopulation, and in parentheses is the percent difference that occurred between the minority population as well as the majority population being white. And as you can see, the values in particular for the ones highlighted red can be significantly different as compared to the analogous subpopulation or white majority subpopulation, with some percent differences even reaching upwards of perhaps 50%. And again, this is just for depression. And just a really quick visualization as well as recap, as well as another interesting finding was that just for sake of time, the other race and Black or African American populations had significantly many differences as compared to the white subpopulations for suicidality specifically. And in particular, we noticed we observed with the Black or African American subpopulation that the crude prevalence rates for Blacks or African Americans experiencing suicidality conditions were consistently higher than the white subpopulations, which has been actually observed in the past, both in literature around social determinants of health and health disparities. So the project impact, we had a great impact of this project so far, and I'm eager to see how we can continue to push this work forward. We presented at a variety of conferences, such as the JuliaCon 2022 Symposium, obviously the OHDSI Symposium, so thanks again so much, and the NATO conference, we're able to introduce the idea of observational health research to the broader all-payer claims database community throughout the United States. And just for sake of time, I'm just going to skip ahead to next steps. So next steps for this work, as this work was funded for a year 2 grant here at GTRI, and I'm very happy to say that we are in the process right now of deploying these network studies at partner sites. So to all my data partners, thank you so much. You all are amazing. Thinking about expanding our baseline and follow-up characterizations at these sites, as well as determining best approaches in composite analyses. As I mentioned earlier, when we look at race and these sort of other categorizations, both in the US and other parts of the world, these categorizations can be very different and very difficult. So be an open question of how we can actually do any sort of comparisons or meaningful insights across the data site partner locations. And then furthermore, we'll pursue work on formalizing further definitions. And thank you to all my confirmed data partners so far. If you want to get involved, we're still having open enrollment. So if you want to be a data partner, let me know. We're currently working with the phenotype definition group to formalize chronic mental illness phenotype definitions. And if you want to discuss final analyses approaches with me, I'd be more than happy to chat. So if you have any questions, feel free to reach out to me on OHDSI Teams. And also there's my email. And here's a huge list of acknowledgements for all the amazing people who've been able to bring me to where I am today with this work. So thank you so much. And Craig, I'll turn it back over to you. Thank you.
Great. Thank you, Jacob. It's a great presentation. Glad you were able to share this work. I know we're tight to the end, so if people have to leave, that's fine. But if anybody does have questions, well, if Jacob can stay, if we have any questions, please feel free to ask now. Of course, we will have these recordings posted later on YouTube.
Jacob, would you mind just saying a little bit more about what you're doing to try to create a network study? So how is that specifically working, and what support can the community do to provide to help you with that?
Yeah, so right now with the network study, it's mostly been contacting the various data partners that we have in the OHDSI community, which has been awesome. GenReps has been awesome with helping me connect with other data partners. And then working with these data partners as we're going through the process of deploying the network package, we're also doing at the stage right now of deploying feasibility tests at these different sites to see if they have the sufficient data that we need to do the various stratifications that I want to research with this study package. But otherwise, so far it's been rather straightforward with, for example, working at Boston Medical Center, we're able to reproduce and run these feasibility studies. And right now, obviously running out, working out some of the kinks in actual deployment, but we're at the stage now where we're actually generating some insights at these various partner sites. So I'm very excited to keep going. So right now, with the overall OHDSI community, if you have any insights about deploying network packages, or if there's any other approaches that might be useful, or if you want to be a data partner, honestly, just reach out, or I'd love to hear from you. So that, to answer your question, Patrick, that'd be my answer.